All right. Today we're going to jump into something that is, this class is all about assessment, as you know. One of the important things about assessment is making sure that what we put down is accurate. Another thing about assessment is we need to be able to look at other people's assessments because we're not the only group that are going to be doing those. And know what they're talking about. So, I talked to you guys in the last class about abbreviations and that we were going to hit up some abbreviations that are common in the field and that we all need to kind of know and be able to recognize and even use, because when you get into a facility, you start using shorthand and you'll be surprised that people that will almost get mad at you for not using the appropriate abbreviations. So, and I'm sorry I had to drop my mask, but I'm far enough away from everybody. I'm fogging up my own glasses, and once I put them on, I can't really see without them. So, so what you can do right now, I want you guys to, now, I did post this documentation and medical charts on Blackboard as well. It's under the content, but today we're basically going to talk about the main things that I noticed when I was going through this. We're at least it's a pretty good little packet, so you're just going to get to watch me stand up here and we're going to talk about the highlights from this, because maybe a little boring, maybe a little bit you're be sitting there like, but this is a foundation of assessments and being able to recognize what we're looking at and write them properly. So it's a good starting point before we really get into trying to do assessments. I want you guys to look at these abbreviations and see some of these things that are important in here, like something that she picked out a little while ago while we were waiting for this class. And we will talk about that. So basically this chapter, and it's in for those of you who are looking at doing CTRS certification, probably want to get that red book, the big pretty red book that I brought in here last time. It's the second one on the list on the syllabus. This is just chapter 8 in that book. I knew that some people would not have it, so that's why I went ahead and just included it. This is just basically a general overview of the practices that people need to use when they're writing in a medical chart. So when we do assessments, we have to, if we don't write down what we find, then we didn't do it. So we don't have a starting point. So you got to make sure that we're writing down what we're doing when we do an assessment. You're going to make progress notes. That's a statement of assessment. Let's see. Basic rules when writing in a chart. Okay. I want you to, let me go back. Over on the bottom of the very, very first page there, the recreation therapist's effectiveness is increased when he or she is viewed as an important member of the treatment team. That's something that has improved, increased, and is still picking up steam, because recreation therapy is being seen as a lot more equal to the other therapies and other groups now, as it should be, because they see what we're able to do with the patients and that the patients want to come to us. And when we're able to show them through assessments and evaluations the things that we are able to get done, then that is increasing. So that's just something I kind of wanted to point out. So for that to happen, accurate, concise, useful documentation is vital in creating this perception, because the way the treatment team, the facilities administration, and the accrediting agencies view the recreation therapist is influenced by how and what they write in the medical chart. So what we're talking about here is important stuff, because that all comes down to other people are looking at these medical charts. and they see how you are writing things in there, and they see whether or not you're doing this in a professional manner or not. Over on the other side, basic rules when you're writing in a chart. You need to record accurate, factual events that you can personally vouch for because you observed, smelled, heard, or touched the event. So, smelled is funny to me for some reason. I mean, I guess it could be a cooking competition or something like that. Of course, I have 3 little boys, so when I think of, I went the wrong place on that. The therapist should write in a timely manner following the basic documentation guidelines. That means it needs to occur in the order it happens. Don't document, note this, like this stuff I'm saying, you need to be taking note of, underlining, highlighting, whatever. Don't document about patient actions before they happen. That is, well, that's illegal. You can't do that. Backdating notes or adding a note at a later date, writing between lines or squeezing in words shouldn't be done either. So you need to do, you know, most facilities have times for activity therapy or recreation therapy, and then they have times for documentation. And there, it's done in a way where you can go provide what you're going to provide and then come back and do your documentation while it's fresh. And you need to do it right then, because that's when you're going to know what you saw and smelled that you can put in the documents. So make sure that you do that quickly. Now, if there is something that you omitted on accident, obviously you would rather go back, go back and make sure that it's correct. It's talking about not going in and squeezing things between lines. If you had to do something like that, make sure that you initial next to it of what you did. Next page. This is kind of important. The therapist should make error corrections by drawing a single line through inaccurate materials and then date and initial it. Okay? Why is that? Why would you want to just draw a single line through? What do you do usually when you mess something up? Do you draw a single line through it? What do you do?
Erase it.
Yeah, if you're using a pencil, you just erase it or use white out, or just scribble it out where you can't see it. Shouldn't do that in a chart, in something that's going to be seen by other people, okay? Never obliterate material on the record by scratching out, erasing, or using whiteout. You don't want to do that in things that are going to be in actual medical charts and files. Make sure that the chart, keep in mind that the chart is a means of communication for the various medical personnel involved in the patient's care, not just for yourself. Other people will be referring to the same chart that you're working in, so make sure that you remember that. You don't need to vent your anger or frustrations at the patient or the family. It gives for example here. Careless, unsubstantiated statements such as the patient's mother appeared schizophrenic may haunt the therapist in his or her facility long after the patient's medical problems are resolved. So you don't want to make statements that are your opinion per se, unless it's a situation where you've been asked by someone for your opinion and you state that in there. I was asked for my opinion. This is what I told them. The rest of the time, you're not putting your opinions down. You need to document. Number 5, you need to document frequently enough to demonstrate continuity of patient care. So make sure that you're doing this on a schedule, not getting way behind. Number 6, therapists should keep documentation concise and specific, but not so brief that important facts related to the patient's condition or treatment are omitted. You don't want that to happen. Number 7, you need to sign and date every entry you make. The therapist should also specify his or her professional title. You know, so if I was signing off somewhere on paperwork where I used to do some consulting, I would check their paperwork and sign off. I had to put my name, date, CTRS there, where when accrediting agencies came in, the watchdogs, to make sure if they're doing things the proper way, they would know who this person was that was signing off on the paper and why I was signing off on the recreation therapy stuff. They need that credential for where they would know what you're doing. Number 8, the therapist should not include documentation about the action of other members of the treatment team in the patient's medical chart. Each professional is responsible for writing his or her own chart notes. So the layman's terms for that one is stay in your lane. Don't be getting off in somebody else's business and writing what they were doing. You talk about what you did, let them write about what they're doing, okay? The therapist should use descriptive words when writing in the medical chart. There's a table that we'll get to that has commonly accepted descriptive words, and we'll get to that. It says the therapist should avoid abbreviations. The only abbreviations that are allowed in medical charts are those approved by the facility where the therapist works. And now this is going to vary from setting to setting. The ones that I'm going to get y'all to kind of look at the back of this thing, and we're going to mark for you to try to learn, are going to be ones that most places are going to use. And that would be helpful for you to recognize. The medical records department at most facilities would be able to provide you with a set of approved abbreviations even. All right. We're going to go to page 159 on there. It's that table 8.1. And it's got some descriptive words that you can use in documentation. And these are the things, the sort of things that we will use in recreation therapy in charting for good descriptions. Tense, rigid, relaxed. Their head was down. That's something that's very clear whether or not that's, you know, that's not your opinion. They were sitting there and their head was down the whole time. They were not engaged. Movements. When I was at the regional center, there was a lot of self-stimulating. You know, you would have patients that rock or put their hand in front of their face and just do this because that's a stimulation that they need, or even tapping on everything. And boy, that would, for the normal person that comes in there that's not used to being in a facility like that, some of that would drive you bonkers until you get used to it. But before long, you don't even notice it. It's just part of life. Dexterity. We know what dexterity is. We need to know what that word is all about. Yeah, the ability to move them accurately, basically. You know, when I reach for this pen, if I have good dexterity, I'm just going to reach and pick it up with 2 fingers. If my dexterity is not very, I may overshoot it. I may knock it off when I'm trying to grab it. Dexterity is a word that we need to use. We'll talk about, obviously, tremor, rocking, repetitive movements. Eye-hand coordination ties into that. These aren't, I'm not going to like test you. I'm just saying some of the ones that I've used when I was making documentations as far as recreation therapy. Helpful words to remember. Demonstrates. The patient demonstrates the ability to. That's a good word. That's a specific word. It shows that they are doing that. As a, you can say, I noted that they did this. That's another good word. Observed is good. See, like, I like observed much better than another one in there that says appears. You know, they appeared to do so and so. It sounds much better if you say, I observed them doing this. See the difference between kind of the definitive words and the not so much. Mental state. They were alert. They were confused. The patient was drowsy. That's something that you can see straight up. Disoriented. They didn't know where they were. This is just descriptive words that are generally, most of these are good to use in documentation. I'm not going to go through the whole thing, but there are things that you can see. What is someone's affect? Their what? If someone has a flat affect, what do they look like?
No facial expression.
Like no facial expression at all. It's kind of like your emotions, your affect. And so you've got down here at the bottom, you have a flat affect. You have depressed, sad, remorseful, belligerent, agitated, hostile, animated, calm, relaxed. That's all about the, state of mind that person is in, their mood, basically, a lot of times. Moves on into the next page. Let me see some of the ones that I've used before. Retains instructions. The patient retains instructions. Like when I tell them how to do something, they're able to understand it and remember it. They need clarification. They learn quickly. These are things that you can check. Do they? Like if you made a checklist, do they need clarification? Do they learn quickly? Do they follow demonstrations? Do they need repeated directions? You would be able to choose which one of those. So that tells you how specific you can be on what you're doing when you're talking about those things. Use of time, works slowly, works steadily, skips steps, choice of activity. Are they decisive or indecisive? Do they quickly engage or do they sit back and wait to be pulled in? These are the sort of things that you're going to make like in daily notes. Tia was present for class, but she did not want to engage. After repeated attempts at getting her to join the group, she complied, and from that point forward was able to have a good time the rest of the day. Yeah, I don't know. That would be much better at the ending, but that's the point where you would use some of that. Let's skip on. That's something that you can take with you. That's why I made copies. If you're going to be making those, that's actually a really good chart that has some good specific words that are professional in nature for the most part. All right, it talks about how therapists can initiate contact with a patient. One way is a referral. A referral is a formal request in writing, usually documented in the medical chart, from another person who has a legitimate interest in the treatment of the patient. A member of the treatment team, a legal guardian, or the insurance company or trust fund supervisor may refer a patient to the therapist. So you can have patients referred to you. They can also be, if you work in a facility where they're just admitted, the next step would be you doing an assessment on them. They just become one of your patients. They don't get a direct referral at that point from someone. Another way to initiate interaction is through a prescription, which is on the other side of that page. A referral is not a prescription. Most third-party payers will not pay for recreation therapy services on the strength of a referral alone. To receive third-party payment, a prescription is often required. Just something to note. that just because somebody says, hey, you should go see Chris, he works in recreation therapy, he can help you out. You need something more than that if you're going to try to bill for what's happening. Okay, I'm going to move on to 162, the middle on the right side. Documentation related to the referral and the initial visit. After receiving a referral or prescription for treatment, the therapist should acknowledge receiving the referral, prescription, and the chart. Therapist notes should reflect information obtained during the referral process. The therapist documentation for the initial visit should also reflect that some of the orders were carried out during the first visit. And you see just below here, there's an example of how the documentation would go from there. On 6/11, you received an order for recreation therapy services, reviewed the chart with evaluation to follow. Very concise, very clear, this is what happened. On the 13th, you're doing some assessment here to find out what's going on. The two primary reasons for the referral were the maintenance of as normal of a developmental progression as possible through the bone marrow transplant process, and to provide the patient with age-appropriate avenues to express fear and anger related to hospitalization and illness. So that tells you why they are there. This thing just has some good examples of how they should be written, how they should look. On the next page, as shown here, you can turn down a referral. At times, the therapist will receive referrals or prescriptions for services that aren't within the scope of practice for the department that they work, or it might overextend the staff coverage. It's not considered professional to document in the patient's medical chart that there's not enough staff at the moment to provide services. Below are some examples of how to decline a referral. Not going to read those to you, but there's a couple pretty good, several right there that are good examples of reasons that you may decline a referral. Everybody here heard of SOAP notes? Pretty much. SOAP notes. That's when you are up to this point, all examples of documentation have been written in the narrative style. When using the narrative style, therapist writes his or her note in the same manner that they would report the information in a team meeting. Some facilities use a style called SOAP. SOAP stands for subjective, objective, assessment, and plan. If the example on the previous page were written in a SOAP format, it might look like, and there's the example below. Let's go, I actually want to, because this is kind of important. How about you read the S to us?
Emily cried. Her mother said she expects me here because I'm afraid they might have trouble. And my other children are upset because they have not seen me for 2 days.
Okay, that's subjective in nature. Oh.
Emily was crying, clinging to her mother and hiding her face from the therapist. In an age-appropriate manner, the room has no toys in it. Mom's facial expression showed strain and a frown. It was obvious for her red eyes and the tear stains on her face that she too had been crying.
Okay, you see the difference between those two right there? Subjective is that happened. You saw that. You objective is a little different. It's not, doesn't include feeling. Subjective includes some interjection of feeling a lot of times. A. Bailey.
Emily and her mom appeared to be upset. Mom did not understand protective isolation procedures related to kids. Mom did not know how recreational therapy facilitates the cleaning of tools for Emily. Mom needed some help with childcare for the two siblings. Therapist knew that Emily would stop crying after Mom was not in the therapist.
See how the three things are saying the same thing, just in different ways? You know, basically. We just need to know what SOAP stands for. We need to know what's going on from there. So P, the therapist questioned the mom in a supportive manner to ensure that she understood the protective isolation procedure as it related to toys. The therapist gave Emily a doll with extra face mask, demonstrated to mom how to play games with doll and mask to demystify the face masks. The therapist discussed the issue of siblings with Pam Ellie, a social worker who stopped in during the recreation therapy session. Arrangements were made to have childcare for the siblings coordinated between the Ronald McDonald House and the recreation therapist therapy playroom to facilitate a more normal family situation. Recreation therapy treatment 3 times a week plus 2 times a week as needed until discharge. Recreation therapy to clean toys for Emily as needed. Those are, P is your plan. And you see how it's very concise, but it lays out what's going to happen from there. Number 6, not quite done. A formal development assessment will be administered when Emily no longer views the recreational therapist as a stranger. All right. I have a bunch of different notes on here. All right, let's take a small break from this. I'm going to come back to this in a few minutes. But if you look at the syllabus, we've got in there, starting with the client assessment portion, there is an assignment where you're going to apply your knowledge and skills of the assessment process. You're going to be provided with a hypothetical case. Using the supplied case study, students will need to submit a professionally prepared report that includes the assessment using appropriate abbreviations and terminology, a prioritized list of needs of at least 3 for this client. So I'm going to give you your first thing that I need you guys to do, where we can get started on this, because it all builds on itself as we go through the semester. I'm going to read you a couple of these, and what I need you guys to do for next class is write up one of these of your very own. And what we're going to be doing is you're going to write up some really good hypothetical clients, and you're going to hand them to me, and I'm just going to shuffle them around, and then I'm going to hand them to your classmates, and those are going to be your hypothetical clients that we're going to use to build this comprehensive report that you're going to turn in at the end. Talked to you earlier about your situation. Still write up one of these for me if you don't mind. All right, this is kind of along the line of what I want y'all to be thinking about. First off, think about the fact that we're talking about recreation therapy. So this is not just going to be Tom who feels great and doesn't need anything. They need to have something going on that we can address with recreation therapy. I'm not going to even say something because I don't want to give you too many ideas and them all be the same. But I will read you a few of these to kind of show you how we want them to be. Sam is a 58-year-old man with no signs of cardiovascular disease. He would like to start an exercise program because he doesn't have the energy to mow the lawn. He would also like to get in a little better shape so he can play with his grandchildren. Although he's not been very active during the past decade or so, Sam used to play college football and ran 3 miles each week until he developed arthritis in his knees at age 50. See how that gives you a lot of stuff that can be addressed. Is that a pretty good example there? Let's see. Beth is a 45-year-old female with type 2 diabetes. She's looking to begin an exercise program. She started eating better and has seen some benefits, but would really like to gain additional benefits through exercise. She enjoys talking with her peers and would prefer to do outdoor activities. Gives you some ideas of what she would like, what she enjoys, what she has going on. George is a 70-year-old man who would enjoy being amongst his peers again. He is very active and walks a mile or two a day. Up until he was 60, George played tennis 3 or 4 times a week and enjoyed being outside most of the day. Okay, where do you think, what is George lacking that can be addressed with recreation therapy? What does he miss? Well, that too. Yep. He's a 70-year-old man who would enjoy being amongst his peers again. Basically, he's not around anybody at this point. He's very active and walks a mile or two a day. Up until 60, he played tennis 3 or 4 times a week and enjoyed being outside most of the day. It does not say that he can't play tennis anymore. You might want to come up with a tennis plan for him if that was one. I'll read you one more just to give you, these are just examples of what I'm looking for. So give your person who gets your hypothetical case study enough to work with. Don't make them a total wreck. You know what I'm saying? Don't give them cancer and hypertension, AIDS, amputation, Bell's palsy. You don't want to hit them with everything, but give them enough that clearly we have something that we're going to work with as far as recreation therapy. Okay, that's kind of the key. Enough, but not overkill. Marie is a 52-year-old female who had a total knee replacement last year. See, as you're hearing these, you should be thinking, okay, what's going on? What can I help? What do we need to address? She had a total knee replacement last year. She slowly regained her strength and has made great progress and is almost back to pre-surgery strength. Before her surgery, she attended group exercise classes twice a week at her local gym with friends. She recently moved to a new city and doesn't have anyone to go to the gym with currently. So, like for her, we've got an issue that she's almost back to pre-surgery strength, but we could still work on, a goal, strengthening the total knee replacement, the leg that had total knee replacement. That would be a goal. Then objectives would be how you're going to do that, what you're going to work on that with. We will get into that in more detail soon about how to write these objectives in the proper way. She also doesn't really know anybody, so she's looking for that social thing also. I'm trying to see if one of these is. Okay, one last one. Leslie is a 43-year-old female who is overweight. She leads a sedentary lifestyle but frequently gets out of the house to run errands. When she was younger, Leslie loved to walk around her neighborhood and ride her bike. She complains of joint pain in her knees. Leslie doesn't meet a stranger and enjoys meeting new people. I like that one. It tells you enough. She needs to be more active. Okay, so for next class, write me up one of those. Don't write your name on it. Unless you want to. Really doesn't matter. You're not going to be giving them to me. They're going to be handed to your compadres and used. Because I want you doing this. Number one, I don't have to sit here and write 20 of them. Number two, it makes you think about what kind of things do we treat with recreation therapy. Give them a couple things that can be addressed because they need to have some a couple, 2 or 3 goals and objectives. So give them some options to work with. Okay? That's due next Tuesday when you come to class. Now, there's more in this paper that I want to go over at some point. This is pretty boring, dry stuff, especially for me just standing up here basically reading it to you. What I want to do next is I want y'all to flip back here to page 173. And I want you to get your pens, pencils, highlighters, whatever you have ready. And I want you to mark some of these that I'm about to name. And I am going to name a lot more of these than you will actually be quizzed on. But it would be good to know all of them that I'm going to list. I don't know, may quiz you on every one of these that I name. Who knows? All right. Starting on the top left, activity, ACT. ADL, activities of daily living. Ad lib, freely as desired. Okay, some of these I'm skipping, some of them I'm not. Like I didn't put ADA because that's not something that you'll probably be having to chart. We know that ADA is Americans with Disabilities Act. Maybe that'll be a bonus on the quiz, but since I talked about it in here. But I'm not saying mark that one. AMT, amount. ASL, American Sign Language. AU, both ears. BID, twice daily, 2 times daily. See, that's a good example right there. You see stuff like that in charts all the time. And if you're trying to understand what other, what the nursing staff is saying or the pharmacy staff when you're going through, you may need to know that they need medicine twice daily because you're going to take them on a trip. So you need to know what BID means. Okay. Kind of like you need to know where if someone says they have hearing loss, AU, in both ears, it may tell you as a recreation therapist that they're not ignoring you, that they just can't hear you because they have hearing loss in both ears. Okay. BM, bowel movement, because that one's fun. Let's mark that one. BMP, nah, don't worry about that one. Draw a single line through it if you marked it. BP, blood pressure. CF, cystic fibrosis. CHD, congenital heart disease. CHF, congestive heart failure. CNS, central nervous system. CO, complains of. I've seen that on charts myself. Patient CO, and you think care of, complains of in that setting. COPD. CP. CPR, we all know what that is. CBA. Now, another thing, when we do quiz test on this stuff right here, be able to recognize to go either direction. If I give you the words, be able to give me the abbreviation. If I give you the abbreviation, be ready to do the words, what it means. And I'm not going to try to pick the most obscure ones that I'm naming today, but these are just ones that I've actually seen in charts and from working in the field for 20-something years. So that's why I chose the ones that I did. Up to the top on the other side, DC, discontinue. DD, DM, diabetes. DNR, DX, diagnosis. EG, for example. EKG. EMG. ENT. ETOH. FAS. This one fits in this class, FIM, functional independence measure. We'll get into, as we get a little farther along and get this, groundwork set, we'll start doing some actual assessments. I like to get this kind of mundane framework built first, and then we'll get into doing assessments. So y'all just hang in there with me, and it'll be more fun once we get to that point. Fracture, FX. GI, gastrointestinal. HX, history. Next page, ICU. IE. IV is intravenous. Lat is lateral. LLQ. The one above it, LE. Lower extremity. Surely everybody knows LB is pound, correct? Okay, I'm not gonna, if I put on there, just consider it a freebie. I'm not telling you to mark it today. Loss of consciousness. Then skip one and the next three, LRE, LUE, LUQ. Then you can jump down to MS, multiple sclerosis. Then the last two, NOS, NPO. Those I have seen on chart a ton of times. Not otherwise specified, and nothing by mouth, NPO. Some of them don't even make sense, to just, if you just look at it, why would NPO or some of these? So don't even necessarily try to figure it out. PC, after meals. PO, by mouth. We know what post-op and pre-op means, before and after operation. PRN, need to know that. Promise you that one will be there. Okay, then look at the, the one below it, let's do it. PROM. It's not a dance this time. Okay, then note the two right below that. You've got PT and PT. You've got physical therapy and a patient. The difference. Know the difference when you see those. PTSD, you actually probably see that charted at some point. Mark that one. Then you can turn the page again. Okay, RICE. Rest, ice, compression, elevation. ROM, range of motion. RUE, right upper extremity. SCI, spinal cord injury. SIB, self-injurious behavior. SNF, skilled nursing facility. You see that a lot of times in like a discharge statement. Patient will be transferred to SNF. That's where you would see something like that, a skilled nursing facility. STAT, immediately. Ever watch ER or any of those shows? You've heard that word before. We need so-and-so stat. That's serious. Okay, down to the T's. TIA, transient ischemic attack. TID, you'll see this. That will be on here, I promise. 3 times daily. TIDM, 3 times daily with meals. TIW, 3 times weekly. TPR, temperature, pulse, and respirations. UD, as directed. UE, upper extremity. VS, vital signs. W/C, wheelchair. WFL, within functional limits. WNL, within normal limits. And then X, times. I think that's plenty, don't you guys? I think that's enough of them to scan over. I'll let you know at least like a week in advance before we're gonna do that. It'll probably be like a week from Tuesday. Just a guess off the top of my head. So if you want to start just kind of drilling yourself on those, you can. The reason I'm doing this so early is because it's basic knowledge that will be used in documentation, and in an assessment class, documentation is a big part of it. Okay, so next class when you come, I need you to bring your assignment of that hypothetical case study. The other thing I can tell you right now is that I'm going to do some skipping around, and I'm going to jump into chapter 4 next class. I'm going to look back through what we were going through today, pick out some of the most important things that I just want to tell you. I'm not going to stand up here and hold this paper like that, but if there's anything else that I feel like you need off of this, I'll give it to you, and I will talk more about chapter 4. We will swap those hypothetical clients, and we'll talk about when the first little portion will be due next class. Any questions or anything from today? I'm sorry, this first part was kind of a little bit boring just coming from this, but it was, hey, tell us what you saw in here that you thought was interesting that you asked me about. I didn't get there to that part. If you didn't hear it, when you're writing in a chart, something that you do is to make sure not to use a pencil. You know, we were talking about not using whiteout. Why would you not use a pencil in a medical chart? Easily erased, easily changed. If something happened to a patient, and say somebody came in to investigate to see what happened, how it happened, and something was written in a pencil, do you think they would like that very much? Not at all. Thought that was a good point that she found, and that's the sort of thing I'm just going to I'll glean through this myself and pick out anything super important from that. The main thing I wanted y'all to get from this page was some of the just high points, and I knew it connected to all the abbreviations here at the end. So you can start looking at that. We'll talk about chapter 4 next time if you have your book and want to do a little reading. Also, get that hypothetical study, and we'll be ready to go on Tuesday. Unless anybody has any questions, we're going to stop there, and I can see if I can beat my wife home today because I have another package coming today. Me and Amazon got a problem. I saw a thing on Facebook the other day where somebody said, I didn't order anything. We didn't get an Amazon package today, but the FedEx driver dropped by to see if I was okay. Y'all have a good weekend.
I learned how to work in school today at NYC.
You did? Oh, yeah?
Yeah.
Cool. Well, that's fun. She thought about it when she got outside, probably. Yeah, you've been down for a while.